Good evening, all the aspirants present here and all the doctors here. Today, the topic is extracorporeal membrane oxygenation, and the speaker today we have here is Dr. Nilanchal Chakraborty, who is a consultant critical care Apollo Multispeciality Hospital, Kolkata. And the moderators that we have today is Dr. ARPAN Chakraborty, who is a senior consultant critical care and ECMO services, Apollo Multispeciality Hospital, Kolkata. And we have Dr. DIPANJAN Chatterjee. He is a head cardiopulmonary ECMO and transplant organ medica super specialty hospital, Kolkata. Dr. Nilanchal, sir, over to you, please.
Thank you very much, Farz Academy and Dr. Asif Iqbal for letting me speak on this topic. I really had sleepless night last night because I have to talk in front of such stalwarts. So without any ado, we just start. So I'll concentrate on the veno-venous extracorporeal membrane oxygenation, especially in adult patients who are having respiratory failure. So first of all, without the history, we cannot progress to future, which usually more mobilized by Dr. Bartlett, who actually put this extracorporeal membrane oxygenation in a pediatric age group with meconium aspiration. Then gradually the oxygenator evolved over time with different other doctors, Dr. Lily Hugh and bubble oxygenator. I can see in the pictures. And today's date, we use as per the ELSO data in more than 24,000 patients, and it is increasing rapidly across the centers. The ECMO centers getting aggregated year by year across the world. So, and of course, it progressed more rapidly after the COVID era. So, we started with more data, more trials, and more guidelines. So, how to select a patient? We should select a patient when the respiratory failure is potentially reversible. So, at the beginning, we may not know whether it's reversible or irreversible, but it has to be a non refractory respiratory failure. And actually, there is no absolute contraindication to know whether the patient is not salvageable by veno-venous ECMO at the beginning. So, starting at 2009, it started with the CESAR trial. They actually analyzed the economic data on use of ECMO. They took patients in the adult age group from 18 to 65. They took the patient who had a Murray score of more than 3 or having a respiratory acidosis causing pH less than 7.2 and severe respiratory failure recurring oxygen concentration more than 80% and a ventilated pressure more than 30 centimeter of water to ventilate them. They took the patient within first 7 days. As you can see, the Murray score, which is basically categorized in partial oxygen pressure divided by the inspiratory oxygen concentration. Chest X-ray, as it more whitened out compared to the blackening, the use of PEEP, and the bad compliance of the lung. So a more than 3 score shows a patient is a high risk of mortality. So they took the patients, and similarly in today's date, the latest trial, the Auxiliar trial, have taken the similar category of patients. They took when the PF ratio is rapidly dropping, less than 50 in 3 hours, they should not wait. When it is less than 80 in more than 6 hours, or the patient still having a respiratory acidosis with pH less than 7.25, they didn't wait for starting ECMO. They tried all before taking them with recruiter maneuvers, paralysis, prone ventilation, high frequency oscillation ventilation, or even inhalation nitric oxide. We also use in our institute reduce the pulmonary artery pressure when the hypoxic pulmonary vasoconstriction is causing strain on the right heart. So these are the inclusion criteria has been analyzed in the ELSO guideline. So the guideline says you include patients when you are ventilating less than 7 days, patient is salvageable, severely hypoxic with PF ratio less than 80 and pH less than 7.2, and you have optimized all other ventilatory support. only absolute criteria which actually cannot be defined at the beginning is if you know this respiratory failure is irreversible and there is no way out to ECMO. Other than that, everything is relative. So, just summarizing again, you include patients with severe ARDS defined by less than 80 of PF ratio, hypercapnic respiratory failure, and all other optimal ventilator management has been failing. So, you don't waste time, put the ECMO cannula. And again, the contraindications are absolute contraindication is none. You can take the patient and wait for their decision to make for lung transplant or any other thing to bridge when you are unsure that this is really irreversible or a reversible respiratory failure. So the relative contraindication list is much more higher. Patients with immunosuppressions, patients having systemic bleeding, chances of cerebral nervous system hemorrhage, central nervous system injury, patient is on mechanical ventilation more than 7 days, or at the extremes of the group in the elderly population. Similarly, other than pneumonia, eosinophilic pneumonia, diffuse alveolar hemorrhage, even with asthma, severely hypoxic, or inhalation injury, these are also special case scenarios where you can use ECMO. Recently, we found a patient, a lady, severely obese with high altitude pulmonary edema who required ECMO almost on the verge of getting a cardiac arrest. Actually, she had a cardiac arrest, and within minutes, she came back when we started on this higher end respiratory therapy. So, what are the basics? We'll stick to basics. The red part is the arterial oxygen content, which is 20 cc per deciliter with 100% saturation, with some hemoglobin concentration of 10 gram per liter. If the flow of the cardiac output is around 3 liter, the oxygen delivery to the body is around 600. That is too much reserve. We don't need them that much. We only need around 120 cc per square meter. And just double that is 2 is to 1 blood supply to the consumption is the threshold for anaerobic oxygenation. So we actually, you can see in the PowerPoint, 600 we deliver, 120 we need, and double that around 240 to 300. Below that, we usually have anaerobic respiration. So when there is a fever or different drugs which increases the demand, or in some fight and flight catecholamic hormonal response, the demand of the oxygen increases. So you can reduce that with inducing sleep, paralysis, or cooling. Generally, adult requires, as per the body weight, 3 cc kg per minute of the delivery. Pediatric needs more, up to the 5 cc per kg per minute. So how we actually calculate the oxygen content, which is a basically multiplication of the hemoglobin concentration, hemoglobin saturation of the oxygen, and the dissolved oxygen percentage is pretty less. So the delivery is that oxygen content of the blood, the cardiac output, and hemoglobin. So for an adult with 10 gram per deciliter of hemoglobin concentration with 3 liter per minute per square meter of cardiac output and arterial oxygen concentration of 20 cc per deciliter, we actually try to deliver 600 cc. Below 240, actually the anaerobic oxygenation starts. So with ECMO support, we try to just overcome that of the failing lungs. So you can see in this diagram also that in our body we usually have a 5:1 reserve for oxygen supply to demand. But when there is a shock, blood pressure drops, cardiac output drops, or hemoglobin concentration drops, the oxygen concentration also drops up to 50%. Then at below the 2:1 cutoff of delivery to consumption, the anaerobic oxygenation begins. So we have to somehow evade that. So when we deliver with a membrane lung, we also target a higher oxygen supply with a higher flow. It can go up to 8 liter. So in case the patient's body surface area is higher, we have to basically target our cannula or membrane or even the circuit supply of the oxygen content in a higher range. But in case of carbon dioxide removal with the same blood supply, we basically require a lower flow because carbon dioxide is much more dissolvable. So if you increase the sweep gas, the carbon dioxide removal rate is higher up. So maybe if the sweep gas to blood flow rate is 1:1, maybe appropriate for oxygenation, but for carbon dioxide removal, even with a higher sweep gas up to 8:1, we may require a lower blood flow for removal of the carbon dioxide. So choosing a cannula depends on what we have in our hand. It can be a single lumen cannula which can be punctured in two major veins. It may be a double lumen cannula, so one a single cannula for drainage and also for the return, or there may be two drainage cannula with one return cannula punctured through the internal jugular vein. So definitely when you use a single cannula, we definitely need a image guidance, and our choices are either a echocardiography, generally the transesophageal echocardiography. So you really need somebody handy with you, or fluoroscopy when you need to see the guide wire progressing from the SBC to the IVC. But generally in our center, we use basically two cannulas. Most commonly, the femoral veins are selected. We take one drainage from the inferior vena cava or maybe from other side, and usually the return cannula sits at the SBC junction. So what it does, it basically makes a series. So it takes blood away from the right atrium and then again returns to the right atrium. Red blood goes, then bypasses the lungs, the diseased lungs, left atrium, ventricle, oxygen content.
Voice interruption.
Hello.
There's voice interruption.
Okay. Hello. So again, in this flow diagram, you can see. So in the right atrium, the red blood mixes, then goes to the right ventricle and goes through the native venous flow, mixes it up, and then that becomes the oxygenated cardiac output. So whatever the oxygen concentration in the left ventricle output we get is a mixture of the ECMO flow plus the native lung flow. So we try to support the lungs until it recovers. So when we choose a cannula, we remember the Hagen-Pauli law, which states that if the radius of the pathway increases, the resistance to the flow drops almost the fourth power of the radius. So higher the inner diameter of the cannula, lower is the resistance. So if we need a higher flow, we need a bigger cannula. So these are the sizes of the cannula we most commonly use. 3 by 8 inch, which has a priming volume of around 71 ml, and of course the resistance is lowest from, if you see from top to bottom, and if the resistance drops, then of course you have to give a higher volume. And then when you have placed the cannula, you can be sure either with a echocardiogram or with a chest x-ray that one cannula sits in the inferior vena cava, the other cannula sits in the SBC junction with a difference of at least 10 centimeter in adult patients. Then you have to secure the cannula well, because otherwise the cannula may dislodge and the positional dislodgement will cause many other complications. Then come the blood pump, which each cardiopulmonary bypass surgery used which is basically not that sensitive to the afterload or preload. It just rotates on, keeps the flow on. So if the cannulas are kinked or any of the circuits are kinked, then of course it will increase the pressure, cause more hemolysis, and maybe sometimes the breakage of the circuit. But nowadays we have the centrifugal pumps, which actually creates a more negative pressure if we increase the revolution per minute. So it sucks in blood and flows it to the outlet. So these are non-occlusive pumps and much more dependent on the preload and afterload. So you can see in this chart, if you want to change in the flow rate towards increasing side, the pump speed you have to increase. So it basically decreases the inlet pressure, causing more flow across the pump. The pump outlet pressure ultimately increases, and that actually increases the flow of the blood across the artificial lung, but it doesn't affect the mean arterial pressure, or sometimes it may increase. Similarly, you can use this chart to basically use your membrane lung for oxygenation when the lungs are diseased. Then the blood goes through the artificial lung, which nowadays we have a transverse flow oxygenator, which actually have some semi-permeable membrane across which the blood flows, and the oxygen also comes in contact across these semi-permeable tubules, and across the diffusion gradient, the oxygen and carbon dioxide diffusion occurs. These are polypropylene pores through which only the oxygen and carbon dioxide can pass through, because RBCs and platelets are much more higher in size. So when you are using a patient on extracorporeal circulation, you have to make your emergency ECMO cart ready for the tube fixations, for the clamp, the syringes, and always make a checklist of things, that the size, the cannula size, where it has been fixed, and what are your flows and pressures going on. But every membrane has its capacity. It is measured by the rated flow. So it is defined by the venous blood perfused through the membrane exits at 100% saturation until a limitation is reached. So oxygenation of the outflow is also dependent on the surface area which comes in contact with the blood flowing through it. So you select your membrane oxygen membrane or artificial lung according to the flow you need for an adult patient, because if your capacity is decreasing, then you have to either add on a parallel oxygenator, or you have to increase the flow with another cannula. So oxygen content is depend on the how much flow going through the membrane, how much is the rated flow of the membrane, and how much is the hemoglobin concentration. Again, the hemoglobin concentration and the oxygen content of the blood varies. So this chart shows that at some optimum level of hemoglobin concentration, the oxygen content is the best. So if you titrate the flow across the membrane lung, you have to titrate the hemoglobin concentration also. But if you cannot do that, you have to increase the suction across the circuit with increasing the RPM. You have to add on another cannula so that you can give more blood flow across the membrane, or you lower the demand with sedation, paralysis, or lowering the body temperature. Or if all these things fails, you have to add another membrane lung. The blue blood comes in, it goes through one of the pressure monitoring system, which is a P1, which is basically a negative pressure should be less than 100 millimeter of mercury. Then across the pump, we measure the flow, which is nowadays uses ultrasonic devices and can detect some minimum air bubbles. With all the saturation, then it goes across the artificial lung, and before that we measure the P2, and after the artificial lung we measure the P3. So difference between the P2 and P3 is the delta P, which according to the flow across the pump, we basically measure the functioning of the artificial lung. If the artificial lung or the membrane oxygenator is clogging, the delta P will definitely rise, but it also depends on the flow of the circuit. Then comes basically the pump console, which has some alarm features, detects the low flow, the pressure limit, if the indirectly the air bubbles or any complication with the flow. So the low flows, I'll show you later in a table diagram, can be because of the inadequate preload. Patient is hypotensive because of the circuit volume loss, maybe because hypovolemic, maybe because of septic shock, or maybe some mechanical obstruction which obstruct the flow across this circuit. The problem as you detect it. So as the blood goes across the membrane oxygenator, it evaporates and loses temperature. So a heated water circuit goes directly to the oxygenator, integrated with it, maintain the temperature around 36 to 38 degree Celsius. Other than that, the circuit, details of the circuit, you have to maintain the physiological optimization of the patient. You have to sedate the patient reasonably well when needed as per the Richmond agitation scale. You have to allow some spontaneous breathing without causing lung injury. You have to allow mobilization when it is appropriate, and sometimes when the patient's demand minute ventilation is too much high, we have to use partial neuromuscular blockage to reduce the demand of the patient. Initial oxygenation goals remain around 80 to 90%, and with the sleep class flow, you target a pH more than 7.3. Do not allow the carbon dioxide to reduce too much rapidly. So other than that, you have to rule out any cause of infection which can cause increased demand to the patient. And as the ECMO days goes on, chances of infection also increases. So as per the ELSO data, the incidence of infection in adult is 30 per 1000 ECLS days. So reduce the requirement of ECMO. Try to mobilize out of the ECMO as soon as possible as appropriate. Otherwise, you check for your infection with proper asepsis. Other than that, there is specific ventilatory management which has been as per the guideline. So basic principle of use of our ECMO is to reduce the ventilator induced lung injury. So try to reduce the lung stretch. Different trials have used different ventilating parameters, but the basic aim is same. You reduce the plateau pressure to less than 25 to 30. You use less PEEP, maybe around 10. Reduce the respiratory rate so that the ergo trauma to the lungs is less. And as you are using artificial lung, try to reduce your ventilatory oxygen concentration. So most commonly thought Caesar trial used a pressure control ventilation mode with 10, 10, 10 in each side and FI2 of around 30%. And the EOLIA trial, they used APRB mode or volume assist mode, but ultimate target was the same. You reduce the plateau pressure to less than 25 to 30, you reduce a less P, and of course give a lesser oxygen. And when appropriate, you allow spontaneous ventilation. Other than that, as we talk about extracorporeal circuit, it is not like our endothelial lining of the blood vessels where coagulation and anticoagulation goes in hand and thrombus usually generally doesn't happen. This extracorporeal circuit actually invites more shear and stress, platelet and fibrin deposition, wall uniband factor deposition, causing increased chances of clot formation. So anticoagulation is part and parcel of this system. Unfractionated heparin is most commonly used, and when there is heparin resistance or heparin induced thrombocytopenia, we use basically bivalirudin or agatroban. Sorry for the spelling mistake. We target APTT around 40 to 60 seconds. More commonly at the bedside, we use the activated clotting time, or sometimes we use the anti 10A level monitoring. So it has both the complications, thrombotic as well as bleeding complication. So you have to monitor for all of them. Other than that, nutrition as usual for other critically ill patients, skin care with bigger cannulas and ventilators and other linings, very much important. Eye care is also important for paralyzed patients who are not blinking. And of course, the psychological support, and most important, the physical therapy. So you have to mobilize the patient as soon as possible. Sometimes the patient are not coughing enough, so frequent bronchoscopy for airway clearance, and sometimes cryoprobe for airway hemorrhage is needed. Hemodynamic management is very important to optimize the flow with inotropes, vasopressors, and optimal fluid therapy. So echocardiography on a daily basis, maybe multiple times in a day, really helps you to know the volume status of the patient. Usually we try to keep the volume resuscitation as minimum as possible, other than the initial phase when the volume loss in the circuit is too much high. But it ultimately, if we give too much restrictive volume, it can cause acute kidney injury, and especially patients with acute kidney injury, similar to the other critically ill patients with ECMO, can increase the mortality. When we use a circuit, more commonly we use CRRT or SLADE, but when you connect a circuit, the basically the dialyzed blood must go before the oxygenator so that it can trace any air bubble in the extra circuit attached to it. Other than that, the dialysis process is same as any other patient. Any procedures on ECMO, even removal of a simple venous cannula with a bleeding risk and coagulation risk, has to be monitored quite scrutiny. So basically, even a removal of a cannula or inserting a nasogastric tube can cause immense bleeding. Similarly, this patient may require tracheostomy, and deliberate, very much important is the use of cautery sometimes to reduce the bleeding in these patients. Use of ECMO more than 14 days as per the ELSO data is called prolonged ECMO, and sometimes the results may not be as usual when it is used less than 14 days. So a decision has to be made. If the patient is doing well before that, you have to think about weaning. So for intubated patient, you see your oxygenation parameters are okay. So PEEP requirement less than 10, FID requirement less than 60. Oxygen concentration with lowest ECMO support is more than 70. Still, you are not causing harm to the lung with tidal volume 6 ml per kg, plateau pressures are less than 28. Respiratory rates are not too high, and your blood gases are quite well. So you think about weaning. So how you protocolize that? Reduce the delivery of oxygen, that is the FDO2, first go down as low as 0.2, that is a 21%. Then you reduce the sweep gas. Sometimes as per the patient, we keep the sweep gas off for few hours before taking the decision for decannulation. Because you have to come out with two bigger cannulas, we keep the patient flat, we prepare for any blood loss with requisition of the bloods, and then two operators generally have to have at the bedside for proper suturing before the cannulas are out. Other than that, we need to know some complications which already have talked, some circuit related complications because of the rupture, plasma leak, overheating or hemolysis across the pump. There may be some cannula related complications because of the guide wire. If your imaging is not that great, can cause cardiac perforation, tamponade, and cannula malposition. Sometimes, of course, the coagulation related complications can be there, which can cause thrombocytopenia or stroke, which may be hemorrhagic or ischemic. Other than that, the circuit malfunction can be simply due to power failure, membrane lung dysfunction, gas supply interruption, air in the circuit from anything around the patient, or maybe simply circuit disruption, or if you have not sutured well, or turning the patients without much notice, inadvertent decannulation also can happen. So you have to be cautious with this patient who is so much sick. Potential sources of circulating air can be from the central line, can be from the tracheostomy, or maybe simply from the cannula itself. So when the patient is on ECMO, and depending on the blood flow, we must be worried at the bedside with this diagram. If there is a decreased extracorporeal blood flow, oxygenation will drop to minimum at the earliest. So we see if the inlet pressure, pump inlet pressure is high, that means that it is having some obstruction. So it may be because of the pump failure itself. When the pump inlet pressure is same, but there is a sensor is failing, then we have to think, okay, there may be some motor failure. If the inlet pressure is dropping too much to drain the blood, there may be drainage insufficiency. It may be because of the hypovolemia or some shock or something else, or maybe some circuit related drainage limb tubing kinking or compression. So blood flow across the pump is not happening. So you have to increase the negative pressure across it. Other than that, if the membrane lung pressure is rising or the delta pressure is rising, we have to think that maybe some clot sitting on the membrane lung. Or sometimes when the post membrane lung pressure is rising, although the delta pressure is low, then we think about the return line obstruction, which may be the kinking in the circuit or maybe some thrombosis in the blood vessels of the return cannula. So this diagram, I'll say that keep at the bedside. So in terms of crisis, you don't have to search much. You just look at what is happening, check the pressures and diagnose what is the problem. So to predict the complication, there are different scores most commonly used to detect the chances of mortality, the RESPO score. So higher the score, I'll say the total score, if more than 6, it comes in the risk class 1. So chances of survival is 92%. But other than that, other scores are also there. The preserved score, when the score is more than 7, the probability of survival is low. But when we give the ECMO cannulas, we really don't think about them. We really think if the lung disease is reversible or irreversible. At the dire crisis, if everything is failing, you have to change some component of the circuit, or the membrane lung or the total circuit itself has to be changed. Then we apply 4 clamps around 15 centimeter apart and ready another circuit at the bedside and do it as early as possible in a hypoxemic patients. So coming to the trials which have been published over time, it usually starts with that Lancet 2009 trial, basically economic analysis in one UK hospital. They also showed that actually the chances of survival in the ECMO group is higher, but the cost of is too much high, around 40,000 pound per patient over 6 months survival. Coming to the latest trial on it, which is also pre-COVID era, which showed that in the ECMO group in this severe respiratory failure, the primary endpoint shows a mortality is 60 days or better, although it is statistically non-significant in the ECMO group. So coming to summarizing all these things, you have to, for a severe respiratory failure in ARDS, when you plan for artificial lung with venovenous ECMO, first of all, you plan your circuit based on your cannula size, body surface area of the patient, and your membrane size. Then you determine what could be the highest flow to optimize the oxygen delivery to the patient. Throughout the stay, you optimize all the physiological parameters, mostly the flow across the pump, the hemoglobin concentration and content, and determine what can be the variables of this oxygen kinetics. If the patient's native lung is improving, patient's condition is improving, you come down on your artificial lung flow, or you just continue the support. Thank you.
Thank you, sir. Well, we have got few questions in the chat box.
Thank you, Dr. Hemant, and it was a wonderful presentation, and it was quite exhaustive and very important for the students. You have tried to cover all the depths and the important studies pertaining to this ECMO therapies. Can I ask one question? We have this earlier trial which has come up and probably seems to be a negative one. But the trial had a lot of crossovers. So how do you take this? Do we really need to collect more data? Whether early institution of ECMO is going to be beneficial, or any particular timing that can definitely help us to institute our patient. Because cost is the biggest factor in Indian continent. So, we have PO to FiO2 ratio that is definitely an indicator, but do you feel like, are we justified in doing ECMO late or we should do it early? So these are my few questions, if you would like to take it.
Sir, thank you for asking this valid point. Actually, in our center, we hardly wait for 6 hours when the PF ratio is less than 80. Even the patient is prone and oxygenation is less than 100, we start counseling the patient. Now, of course, talking about the finances. So everything should go hand in hand. Of course, this is not charity. So when everything falls in hand, that financially patient is okay to go on, at least at the beginning, and then everything matches for the patient that it is a reversible cause of lung disease, then it is quite appropriate to start on ECMO. But I'll say, in my experience, very short-term experience, although, if the patient survives first 14 days, then beyond that, if the patient is still requiring higher support, it is really a 50-50 chance whether that patient will really come out of the ECMO or not. Nobody knows. Even the also data doesn't say. As per the earlier trial, of course, the trials are good, but they are not good at the bedside. So when you see a patient, actually individualize the therapy for them and decide as per that particular patient, whether that is young patient and PF ratio is falling and the patient is really less time on the ventilator. So in that case, we do not think much. We just try to gather the finances for the patient. But of course, when there is some relative contraindications with background of cancer, extremes of age, and some other complications, we really give it a question. And beyond 14 days, even the data is not strong enough that those patients probably will come out or not. Of course, my experience is pretty less. And even in 100 patients, some one or two patient comes in, that is, I'll say, is really a rarity. But for first 14 days, definitely the finances helps. We can try.
Yeah, we have Dr. Arpan. Arpan Dada, you are there? Arpan Dada is not there. So we have seen a lot of deaths, particularly in COVID, pandemic, and the mortality was very, very high. We had less than 20% of success in our setup. Where we tried ECMO and we miserably failed as far as the outcome benefits were concerned. And yeah, COVID was a different domain probably, but yes, patient presenting with viral illness, ARDS, uh, with poor PF ratio. I think rather than recruitment maneuvers, of course, if the prone positioning has also uh, 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 failed probably, so I think early institution of ECMO can definitely prevent lung injury. So we basically put the patient on ECMO to prevent lung injury, so that lung gets some time to recover, and the disease process has its own course actually. So I think we should decide about putting ECMO only to prevent lung injury. That should be the concept, rather than taking ECMO as a therapeutic advantage. I think Dr. Dipanjan would like to say something. He's
Yeah,
also.
well said. Because ECMO is VV ECMO. When we are putting, the lungs are worsening, and to prevent further damage because of the barotrauma and the volume trauma that we are inducing, to prevent that and to give the lung rest, ECMO is never going to treat that lung injury. It's only the only way that the lung can improve is by getting a rest. If we continue with a high airway pressure ventilation, even if the ABGs are more than PF ratio is more than 100, and your airway pressures are too high to maintain all the parameters, then again we are going to lose the patient. So the earlier we put the patient on ECMO with and prevent further lung injury, the better. And how long the patient will need, it is not in anyone's hand. It is all the natural progression of disease that will determine how long the patient will be on ECMO.
Oh yes, yeah, I
And
totally
sometimes some of the times we are lucky if it's the consideration improves and normal lung architecture is there. And sometimes the patient, some we have faced that after around 3 4 weeks the consideration is improving, but we have a fibrotic or bronchiectatic changes all taking place. We not able to come off ECMO. That is the worst part.
yeah. So I would
Nilachal,
like
well
to.
presented.
Yeah,
Well
yeah,
Thank
presented.
you, brother. Thank you, brother.
yeah. Congratulations to you.
One thing that I want to appreciate that you have put the emphasis on the basic physiology and the need for a higher hemoglobin levels to increase the oxygen delivery to the tissues. Thank you.
Thank
Thank
you.
you.
Thank
Oh, that was wonderful. There is one question in the chat box. Can we take this question?
you. Yes.
Yes.
What is the
Yeah,
question?
yeah. There's one delegate from Solo. I think her name is Gali. She would like to ask, how do we manage if bleeding occurs when we use anticoagulation during ECMO, and uh, indications of ECMO already has been discussed. But if there is a torrential bleeding, how do we handle this situation? Dr. Nilanjan, would you like to take this question, Dr.
I
Dipanjan?
suggest that sometimes in last few cases also we have basically thromboelastogram to see where exactly it is problem, and then we transfuse accordingly. Correct that. Of course, we have to stop heparin if it is going on. We have to reduce the heparin infusion ACD targets unless your membrane is also coagulating. Because if it's a bleeding patient and the artificial lung is clogging, then there is nothing can be done much. But if the bleeding is, you can stop with some amount of transfusion of anything without clogging the membrane, then it is fine. So you do a take and find out what is the fibrinogen deficiency or platelet deficiency or functional problem, or it's too much heparin. Sometimes you can do with ACT, and accordingly that, because sometimes we cater patients who develop even after removal of the ECMO, it's GI bleeding. So last few cases we did the thromboelastogram and transfuse as per the report. That is the best thing at the bedside.
Yeah, Dr. Dipanjan, you would like to add? Yeah, I would like to say something. The intracranial bleed is one of the dreadest complications that the clinicians can imagine. If the patient bleeds intracranially, there is no option and there is no further way. But if the patient is bleeding through GI tract, when the patient is bleeding through oral cavity, or the patient is bleeding through digits or different areas except brain, you can definitely monitor that. That's why it is recommended that anticoagulation should be monitored. Especially when the patient is on heparin, APTT or ACT monitoring is very important. ACT monitoring is bedside, quickly available, and you can monitor it, in real time probably. Whereas in APTT monitoring, the lab test takes some time, maybe a couple of hours or so. So it may not be a representative of the current coagulation status or the bleeding status. So it may represent a bleeding that must have happened a couple of hours back or so. So that's why though APTT, the sensitivity of APTT is better than ACT, but if you want to have quick results, the ACT monitoring is very important, and generally the recommendation is 2 to 2.5 times the yeah, ACT levels is recommended. But if the patient is bleeding, ongoing bleeding is quite torrential, it will give you values of platelets and fibrinogen and clot factors, or if the patient is in coagulopathy, clot lysis time also will help you to evaluate the therapies to strategize. Because it's not just the platelet transfusion or fibrinogen transfusion or FFPs or cryos, but we also need to evaluate what stage of coagulation factor or deficiency or coagulation pathway is affected. So that's why frequent TIG monitoring can definitely help you. You can institute FFPs, cryoprecipitate, and if you are afraid of volume overload, factor 7, activated factor 7s are also available, and plasma concentrates are also available. If the patient has coagulopathy, you have tranexamic acid that you can give, and if there is platelet deficiency, definitely platelet transfusions will be important because when the blood flows through these membranes, the membrane loses its efficiency. The qualitative deficiency of platelet is seen in patients with ECMO. So platelet transfusions also may be required in these cases.
Nilachal, there is one question, good question
Yeah.
in the chat box.
Yeah.
That is, any specific guideline when to withdraw ECMO support in case of no improvement? Would you like to take this?
Yeah, first of all, there are the patient should be waiting for transplant if the lungs are not improving, or we don't have a lung to transplant, so it's bridge to no hair. So this is very, I mean, delicate question. We sit with the patient relatives and administration and association to decide that we have seen enough. We don't have the lung to replace. So at that time, when there is non-improving lung and there is no new lung to give, then that is the time. Patient will die of complications of it. Prolonged ECMO or prolonged critically ill, whatever you say. ECMO is a form of support. So when there is no improvement or no bridge to destination, we call it a day.
Yes.
Is there any timeline?
There is no timeline. As I said, as per the ELSO guideline, 14 days is the cutoff for prolonged ECMO. And sometimes even after that, we have seen few patients coming out of that, but still it's rare. So when the patient is developing lung fibrosis and really cannot survive without a transplant, that is very difficult to say. As per, I mean, seniors like you and Orpunda, I think some patients survive even after 100 days. But of course, those are very rare patients. So chances of lung recovery is less when it is a month long. And if we are not getting another new lung, so it is bridge to nowhere. So at that time, no definite time, of course, but at that time you have to sit together, individualize the patient, see the CT scan, and then decide.
Yes. Now, let me ask you one question.
Yeah.
How do you serially assess that lung? Maybe it's a prolonged ECMO. Suppose we take it as a prolonged ECMO, 1 month is over, and relatives are asking you questions that how long you want to continue, and what are the chances, etc. So, what are the things that you are going to check, and how frequently are you going to do that to assess the patient? The
Before
Suppose that it is only a single organ. The lungs are have been affected. All other organs are okay. You have done a tracheostomy. The patient is mobilized. The patient is sitting by the side of the bed, doing cycling, etc. Everything that you have done, all physiotherapy, communicating, taking food orally. Now what?
So basically, it's not about the day. In daily basis, in day and night, we see how the lung compliances are, and even the patient's lung compliance is not improving, requiring higher pressures, not tolerating even a brief disconnection or lowering of the artificial lung support. Even reducing the RPM reduces the oxygen saturation. That means the lungs is probably not improving. And day by day, even 2 ml per kg of ventilation raises the plateau pressure. So no question about 6 ml per kg in those patients. You know what? In my brief experience, I have seen. So if there is some bronchoscopy, some removal of secretion, some physiotherapy doesn't improve the lung compliance, or maybe the native lung oxygenation, then those patients rapidly deteriorate with reduction of the artificial support. So those patients we assess daily basis, maybe day and night. If the plateau pressures are rising and oxygenation is falling, then I think the patient is non-improving. But of course, in individual patient, 14 days versus 28 days versus 6 weeks, we do not know. But I think we see those things.
Yeah, and just want to add one point that we check the CT scans. X-ray we are doing daily, but
Yes, yes.
X-ray is not a very good does not give us a lot of information which the CT scan can give. So if you can do a CT serial CT, maybe
Yes,
2 weeks apart after starting from the end of first month,
yes, yes.
that will give us a little bit more idea of how the constellation is changing, whether the patient is improving or not. That is one more point that you can add.
Yeah, thank you.
Thank you, Nilachal. Very well demonstrated.
Thank
Is
you.
there any role of two things I just want to ask? Role of proning, when will you do it, and role of steroids?
Uh, in my experience, rule of steroids usually comes in first 7 days, not beyond 7 days to 14 days. More than 14 days is harmful. Less than 7 days, you can try. And if there is a pathology which will be reversed by steroid, like any inflammatory pathology underlying that. So other than that, rule of pruning, of course, if with pruning, sometimes in our few cases, we have seen mobilization of secretion and lung compliance improves. It will be seen in the first pruning. In one of our patient who was a doctor, actually required multiple prunings, which actually forgot how much prune we did. And every time we kept the patient supine, he has to accumulate his secretion at the basis and then again deteriorate. So proning is always very much immediate effect. The patient helps with proning, ECMO only supports, secretion gets mobilized and patient oxygenation improves. So proning in ECMO for prone responders is good because ECMO just does support only for a few days. So ultimately, if there is lung recruitment after mobilization of the secretions, then really proning helps even in ECMO. But if the patient on ECMO, we prone and still the oxygenation remains the same. So those are non-responders. So in that case, we do not prone again.
Yeah, that's really great. So even patients on ECMO can be prone. So that is one learning message.
Yeah.
There's one question in the chat box. How do we reduce the morbidity and mortality while patient is on ECMO? Dr. Nilanchal.
Of course, the mortality thing is that you are reducing the lung injury. Um, So with the support, you reduce the ventilator parameters, you reduce the lung injury, and you expect the lung will recover and patient will come out of the ECMO. So it's a disease process which has to be reversed. And for the morbidity thing, I'll say that your sedation, paralysis, and physiotherapy and nutrition, and most importantly, the infection prevention has to be optimized. If the patient is coming out of the ECMO and on the during the weaning he acquires another infection and goes in the circuit for another 7 days, then ultimately that increases your morbidity. So these are very basic things which are still evolving in our Indian scenario, especially the nutrition and infection control part, and of course the physiotherapy, which can actually reduce the morbidity for patients on ECMO, especially the patients who are young requiring short-term ECMO. I have seen good results in my brief experience.
Yes, exactly. You're absolutely right. The iatrogenic problem should be as minimum as possible. Secondary complications like infection can be detrimental. And basically, you need to rehabilitate early. So these are the key aspects of reduction in mortality and morbidity. That's fantastic, Nilanchal. If the patient is on, awaiting the heart transplant, can I ask this question, Dr. Nilanchal? If the patient is waiting for heart transplant and, sometimes the family refuses, uh, or financials also may not be sound enough initially, and patient would like to go for destination therapies. How feasible is the destination therapies? I have seen a lot of patients who prefer to undergo destination therapies rather than undergoing heart transplantation. So, what is your experience on this?
Unfortunately, in my current institute, we have not done that yet. We are waiting for that. But of course, as per the literature shows, ECMO can be used as a bridge to transplant. We have transplanted one patient on lung transplant actually. So we have done last year one lung transplant on ECMO. So I think for the organ support for the heart will be the same, except you have to take a VA course initially for any other transplant actually when the patient is hemodynamically unstable, and then gradually move back to the VB support when it is required. So for during the
Yeah,
transplant, we go for the VA ECMO. We went for the VA ECMO, and then gradually we reduce to the VB part.
yeah, the VA ECMO can be converted into VAD procedures, whether it is left ventricular assist
Yeah.
device or right ventricular assist device, and even biventricular devices also are available, with which we can bridge patient till patient undergoes heart transplantation. But now, destination therapies have made a significant comeback, and there has been a significant revolution in these VAD procedures, and probably patient becomes battery dependent. But yes, but if he is not fit enough to undergo heart transplantation, especially if he is nutritionally not well or he has other issues with which surgical procedure is not possible, probably these VAD procedures, which is a conversion of ECMO to VAD. So these are also newer therapies which are possible nowadays, and it has helped the patient. I've seen patients with destination therapy for over 10 to 12 years also surviving and having good quality of life, you know. So I think these can also be thought of. Any other question in the chat box, Dr. Nilanjan?
I don't see much.
Yeah.
Yeah. So
What are
um,
the steps involved in weaning a patient off ECMO? I think you have covered, but would you like
yeah.
to?
Yeah, so first of all, we increase the oxygenation by increasing the blood flow across the artificial lung. So first of all, we go down on the revolution per minute, so that we come down to around 1 liter, uh, and then of course we sweep off for a few hours. And when basically at that time patient depends only on the native lung, we see for a few hours with the sweep off 21% and lowest possible flow across the artificial lung. Patient is maintaining oxygenation, hemodynamics, no arrhythmia. Patient is conscious, lactates are fine. So we think the oxygenation through the native lung is appropriate. So we go for decantation. Usually give 24 hours time, as we know, depending on the patient's bedside scenario.
Oh, yes. I think that's sufficient.
Okay.
Uh, I think there are no more questions, and in the interest of time, I think we can wind up the session. But would like to hear key points that you would like to give it to our participants, about ECMO.
So first
Just
of all, there is no absolute contraindication. If the disease is reversible, you can try with venovenous ECMO for oxygenation support in severe ARDS. You do the meticulous monitoring and care of each individual thing of the physiology at the bedside. It is very similar to any other critically ill patients. Avoid any other secondary complications like infection, maintain good nutrition, physiotherapy, and decide when to wean off the artificial lung support.
yes, it's very important. And but one of the important aspects that I would like to also highlight is everyone should undergo some training program when you start with the transplants or ECMOs. I think also recognized uh, ECMO training can be done abroad and even in India. They also recommended programs are also available. Everyone should go hands-on training, though it has a learning curve, but unless you undergo hands-on training, the intricacies of ECMO management will be poorly understood. So I would suggest, those who are really very keen to initiate ECMO programs in their centers, I think it's prudent to undergo a training program for ECMO in
Ye-
whatever
So,
way. Yeah,
yeah,
I hope
so
you
in our Apollo Kolkata, we have running a fellowship under Dr. ARPAN Chakraborty, and of course, we have few other centers in Kolkata also. So they are very much active. We see a lot of complicated patients, and every year, ESO India runs a fellowship entrance exam, which actually last 25th December it was, and then the fellowship will start from this January. So everybody can access the website and join the different fellowships programs going on across India in different centers, and contact Dr. Arpan Chakraborty.
fantastic. These are recognized, university recognized ECMO programs,
The
fellowships, or
ESO India, I'll say. Uh,
okay.
yeah, also recognized centers, and ESO India, ESOI recognized.
Yeah, I think there is one question how to join this fellowship. I think you can visit the website of even Apollo or Kolkata website. You can visit and go through the fellowship programs and enroll yourself for these fellowships. Okay, Dr. Nilanjan, Dr. Dipanjan, it was really wonderful having you with us for this program, and especially Dr. Nilanjan, you have had a very crisp insight into the ECMO related theoretical aspect that you have covered, especially the physiology and the complications. That was phenomenal. Hope to see you again. And today we can wind up the session. I hope if everyone agrees, we can wind up the session.
Thank you very much.
Yeah. And bye bye. Good night for now. Thank you.
Thank you, sir. It was a very nice session.